Thank you. Thank you, Himanshu. Thank you, Ravi, for inviting me. And when Ravi first asked me to come, I immediately grabbed the opportunity, and I realized what I would have missed if I had not come. It's a great conclave that you are having, as well as a great place to have this conclave. So I am, of course, as Himanshu was saying, I am a professor at the Johns Hopkins. I'm now a professor at Carey Business School, but I also work a lot on digital health and AI, and we have recently started a Center for Digital Health and AI at the Carey Business School. I do work a lot on the AI ML and, of course, in the finance area and fintech and predictive modelings for credit risk. But the similar things actually applies for the health risk. So actually, that's where the initial segue I had. But also happened to work on the microscope with my brother's lab, who is at CMU and Pitt at the medical school, and publish in some of the health and medical journals, American Medical Journal of Heart, and etc. But most of my work is on AI and ML and generative AI, and I'm going to talk specifically on healthcare today. So I'll give a little bit of introduction and motivation, of course, about what we're going to talk about. And from the title of the talk, you got the idea that this is about artificial intelligence and health equity. And hence, we are going to talk about bias in various healthcare-related data. And that's where the moment we talk about bias, we kind of start to associate it with something with immoral or immorality, that somebody is doing some harm. But that need not necessarily be true. I mean, we might be kind of introduce some bias inadvertently without knowing, because we actually didn't know the context. And this is where I loved Sinjini's point, that if you have to know under what kind of data you have and where the data is coming from. Unless you know that, you're going to do a lot of harm to that extent. And given that we have a lot of predictive modeling going on, if we are not very sure about what the data is coming from and the context, we might inherently introduce the biases in various contexts. And that's where I am going to talk about a causal framework to debias, that if there is any bias, the framework will automatically debias. And I'm going to talk a lot more during this talk on this topic, and the theory behind it, and how I should implement it. And I'm going to show one implementation with one example from a public database, but of course it has wider applications across the board. And I have much, actually more exciting results from some private databases, but I cannot show them yet until I get the consent from the providers. So I'm going to talk about one implementation from a public database, and then I'm going to conclude on that. Just a brief introduction and overview that, of course, we have a lot. So the source of data, and given that we are talking about AI, ML, health in India specifically, we have a rapid growth of cellular connectivity. We have huge amount of people who are now have access to the data through their mobile penetration rate. So all these things are really great, and we have seen the impact of that, for example, in various different sectors, where we saw that, for example, if you think about, since I'm a professor of finance, if you think about the financial sector, a couple of years ago when I came pre-COVID to India, I used to have pay everything in cash or somewhere in credit card, very rarely with anything else. But I come this time in India, and everywhere else I see using the QR code, which you actually is unthinkable in most of the parts of the US. People still use checks over there. So we kind of leapfrogged, right? And here you can see the same idea that the penetration of financial services was very limited, and that's where the digital effect, and hence wherever AI ML is necessary, kind of leapfrogged and help us to achieve a better state of mind. Same thing applies for the healthcare services. We have a very low penetration of healthcare services throughout India. That's true. And given that we have such a huge digital connectivity, which gives us a plethora of data, we actually can use that to leapfrog. And as Ashok was saying in the beginning, in his introductory talk, we are kind of in the midst of that revolution. And of course, with the rapid advances in AI/ML over the few years, we can potentially harness that data. We can now, as Ashok was saying earlier, talk about personalized medicine and use different other types of data connected to the medical data and see if we can get a better kind of predictive outcome, which can be preventive to some extent. So now the question comes in with the types of data, and if you do not use it without the context, there could be potential bias in healthcare provision. So for example, a review from 2018 says that medical professionals were more likely to dismiss chronic pain in women than in men, more likely to recommend white patients to bypass surgery than black patients. Similarly, there are many other biases against potential groups which are potentially coming from because the provider actually behaved differently to one group versus the other group. But that need not necessarily be just because of the provider. So for example, and this is where I kind of relate the bias not necessarily due to morality, but something else. So think about most of the data that you do for research on skin cancer is actually came from the white population. For melanoma detection, if you are using that data, it's likely that people with dark skin are less likely to be diagnosed earlier for cancer detection than if you had used that data from the white skin-based data. Now, that is one kind of bias, which is nothing to do with morality or anybody's ill intention, but potentially is related. And suppose think about we use this data to use in the AI/ML framework to generate predictive medicine, we are going to get underdiagnosed by one group versus the other group, right? So how do we take care of that? We have unobserved data as a proxy. So this is a Nature article recently, which looked at that they kind of, there's an algorithm, not an AI/ML algorithm. They try to proxy people based on different likelihood of whether they're going to be more need for healthcare access or not. And they kind of use, you do not know whether people are going to get more sick or not. They want to look at how much healthcare cost you actually incurred in the recent past. Now, the point is that if you do not have access to healthcare, you're not going to incur much healthcare cost. So if you used a proxy, which is not a perfect proxy, that is going to significantly bias this against the black and the minority people, right? So that's happened with a simple algorithm. Of course, we have the racial bias of the provider. We talked about some of those cases. And I'm going to talk about one running example. And I'm going to show this running example later with the algorithm that I'm going to talk about. Think about the insurance provision and drug prescriptions. So think about if I have, and this data is coming from the US, if I have data, the insurance provider is a private insurance provider, which is more difficult to access because a private insurance provision generally comes through your job or if you're well qualified and you can pay a lot, versus government provided, which is Medicare, Medicaid, and if you're self-paying. And then you try to look at that, does that affect the drugs prescription predictions in the ICU by the doctors? And if you look at the distributions, it does turn out that the private insurance provider is actually prescribed a lot less, relatively speaking, than the other different types of insurance. Now, you can think about this. So these are the kind of simple numbers, summary. Private insurance provider are prescribed about 14 drugs per day. This is from the ICU data in the US. I'm going to talk about the data a little bit later, called MIMIC3. And the not private insurance is 23 per day. These are the prescriptions, and that this difference is statistically significant. Now, of course, you can talk about a lot of other things. We need to control for whatever disease and other stuff are. We'll do that later. But think about there are two inherent things going on besides all the data and other things, which is the two things. One is there is a moral hazard issue potentially that depending on whether the private insurance provider has a better monitoring mechanism, hence the doctors do not prescribe unnecessary medications to people who has private insurance. And two, does the private insurance, those who acquired, is there a selection bias? People who has access to private insurance potentially will have access to better jobs, probably are more wealthy, and so on and so forth. So again, this is a running example. I have actually much better striking outcome with some private databases, but I'll work with this data, this example going forward. Now, this kind of leads to the question that, well, if the underlying training data is biased, if you're using an AI and ML-based device for prediction or healthcare service design, is this going to lead to unfair decisions? Now, this unfair decision maybe actually need not be unfair morally, but unfair to, for example, I talked about the cancer examples. So this could be because of the statistical discrimination or historical disadvantages, but also it has huge important underlying root cause, because one group of the data sets is coming from only one group of individuals which are not transportable at the same way to the other group, right? So, and of course, if you have a nonlinear and black box nature of the machine learning algorithms or advanced things, you have no idea. This biases could be accentuated, which might lead to much worse outcome if we are using the AI/ML-based devices to use this data to predict whatever predictions we have. Now, what are the solutions proposed? One is, of course, you re-weight. Or do some pre-processing, or before you train the data, use the training data, change the data a little bit to make sure that this is kind of not underrepresentation gets over-represented. You do balancing and so on and so forth. So all those things are have been proposed. But the question is how and why, and this is again, unless you really know the context coming from, you are really going garbage, because you will not be able to do that pre-processing. So here, what about this presentation is, let's look at a model, which is based on causal analysis, which will kind of look at the decision-making process with both sensitive attributes and of the sensitive and non-sensitive attributes. We can talk about, do I modify those algorithms? Algorithm, debiased algorithm, which have the biases that data. Okay, so that's what we're going to talk about. Ask the causal question: what would the algorithm applicant or patient, he or she achieve the same test if it was a test example or anything? So how do we do this? So think about model. So think about the outcome, which could be any risk, including. This is the. I gave two different features: the race, gender, or attributes that you can think about, or ethnicity or religion potentially is out there. The other, an example of location, you can think about these. This could be else, and it does not have to. It could be multiple other variables. Now, both of these affects outcome, your health risk. So that's the causal channel. But your race and also affect, for example, being overexposed for disease and hence observed outcome, right? So there is, which is there in the training data. If I use this data, then I'm going to get learning-based prediction. So this data amount of interdependence of different with the sensitive attribute. This is what sensitive attribute, or S, is the observed. Other attributes are as A. I do not take care of the linkages of this. I'm going to biased outcome in the machine learning prediction describing earlier. So in other words, if I take the and then I debias, I'm going to talk about these two criteria based on 2 minutes, okay. How do I get a different distributions of this? And here I'm going to talk about two versions. The other is affirmative action. For example, equal opportunity will give for different groups the same way. Minority group may have lower access to action could be you have lower access to health, likely to be sick, right? So you really make sure that whenever you prescribe a minority group, you actually do, which is affirmative, giving up an affirmative action that's over there. Think about this in the context in the cancer example, right? So the data coming from the white colored people, but you have a candidate who is non-white. So you need to generate that kind of to an algorithm to generate that. So how do I do that? Of course, this is what I do that. So here it's same sensitive attributes. This is the same levels of other criteria. If you change the sensitive attribution, should be the same, right? If you are generating for the affirmative action, is that take this out sensitive attributes, but attributes actually affected their, so your access to healthcare is affected by this. Change this S prime to a different ethnicity or different skin color, S prime is going to change too, and hence different outcome. Now, if I want to make the same, how do I generate that? With the affirmative action distribution. So a predictive algorithm from the apply these changes, we call opportunity algorithm or distribution, and then I apply this to over this affirmative action based distribution. So there are the I might skip here. I'll talk about this. The point I want to talk about here, that when you are generating S prime, and how is this S, I have to generate that counterfactual distribution. Generate the counterfactual distribution coding stage. Instead of having one particular outcome of A, I have outcomes, so that I have a representation of this distribution. If I do this, I can come up with this F of AA. And to this in the paper, and here I kind of apply this to the mimic. I'm going to skip in the interest of time detailed data, but which has the data related to the various of the individuals. If I use and let's talk about, go back, same examples that I had per day by insurance. So if I actual distributions, and if I first VA loss function, you can see that's look. I want to talk maybe so for a half a minute, just apply a simple. It says if these which are this geometric, which if it is close to 0, that means in the data. If these are, there is potential bias against the other disadvantages. And here I'm talking in terms of who have private medical insurance. See that in both cases, the actual algorithm is going to generate significant biases towards the disadvantageous group. This is interesting. If I bring down, take out the gender in the machine learning prediction, actually means it kind of becomes predictions for everybody, which is likely to be the case. Taken out the gender from this and is 0. But A is still, you still are not representing the addressing the E of the random forest of, but A is still close to 1. Same. At the moment I do A random forest, almost a little bias over here. These are 0.00 something, so I realized it to be close to 0. It kind of says that, well, and again, this goes back to the bias correction provided by I have worked on, that a new algorithm based prediction, plain vanilla machine learning off the shelf, generate a prediction on the training data, filter, generate a new set of random forest under the U and AA, and this generates a new distributions. So here I'll kind of stop in terms in time, we talked about inspired by Paul and Bloy. We applied this, gave you one examples to mimic 3. These numbers are still to be tweaked and trained a little bit better.
Thank you. Thank you. Sudip, any questions? Yeah.
So here, as I said, that this A here, I just showed one node, but you can think about there within this A. It's like a vector. Of course, I couldn't show everything in one graph. Okay, this A could be multivariable.
I see. So then my question is, know the full causal information, the structure nodes. So how would the predictions be? So that is able to debias, but how precise should we be with the causal?
So as I said, it's a work in progress to train and tweak and do a lot. But the good important thing is that not only because many other things where I do not know the node, there may be many other unobserved variables, right? For example, of private insurance, there could be which I do not know why they selected. A moral hazard by the because the doctors kind of looked at the private insurance. Well, they're going to monitor me more, behave differently for them versus there. The underlying assumption for this causal graph, theoretically, the mechanism is that there is no backward path, right? So it is not going to affect. As long as you have that, we are fine. Now, that's of course theory. In implementation, we need to tweak and see how things change as we move forward.
Okay, thanks.
Thanks, Sudip. In the interest of time, one more.
Ravi.
Sorry, I'll. So your model doesn't.
It has. So this here, so you could potentially have as a confounder here could be there is a selection here, and that's why the VA is the variation auto encoding. I didn't go in more detail, but it is potentially.
Yeah, my question was in the same asked. That is, if there are number of variables, one of the potentials I can think about is in study, that is drug toxicity in newer molecules. So toxicity studies some of the aspects or certain drug is considered toxic at this moment stands. A lot of parameters take into account the way it should. Often, say for instance, just to give an example, if steroids is something that ocular pressure elevation. But when it comes to steroids, patients in the study group who got a history of intraocular pressure or other genetic factors. In cases, the drug may wrongly be to the condition. So, to solve with ML. But parameters that involve just explore something like 2030, and few of them are not correlated. We have to use medical data. So I guess I mentioned it's work in progress. And this has got a potential to use a number of parameters, right?
Yeah.
Okay. So we use the same technique. What is going forward to have of unconnected mutually parameters?
Absolutely. So to that kind of false responding to him as well as to Ravi, is potentially this kind of unobserved might be there. But these are this. Maybe I'll take after the offline and then for the specific context that you were talking about.
Fine.
And address this in more detail.
Sure. Thank you.
Thank you.